Welcome back to Do No Harm, where we fight for patients and against identity politics in healthcare. Podcast hosts Benita Cotton-Orr and Dr. Stanley Goldfarb will highlight the medical industry's most pressing issues and dangerous trends, and discuss how we can achieve a better healthcare system for all.
So Stan, let's talk a little about the medical students that are being introduced and educated in these woke policies and this woke approach to medicine. How do we get these students to become aware of this and understand how to respond to this kind of the woke approach in the medical schools, for example?
Yes, it's a problem for sure, because again, there's a great hierarchy in medicine, and students are at the bottom of this hierarchy, and they chafe against it to a certain extent, but they also realize that they need to accept it. For example, at the end of their 4 years of medical school, they're going to look for residency training programs. They very much depend on the proper recommendations that their faculty members give them. So they feel at risk.
So are you saying there's some kind of intimidation factor going on in this?
Well, I think they feel intimidated. Even if the faculty isn't trying to intimidate them, they feel intimidated because they know if they're troublemakers, for example, then they'll be cast as troublemakers when the time comes for them to seek out their postgraduate training programs. And nowadays, a troublemaker is someone who decides that they have heterodox views compared to what's accepted, which is the sort of this woke initiative that's being pushed by major medical organizations as well as the medical schools themselves. Having said that, we had at least one student who wrote to Do No Harm in a way and complained that he had gone to more lectures about pronouns than he had about kidney disease so far in medical school, and he was concerned about that. And I think there is a small group of individuals acting in a sub-rosa fashion who are very concerned about this because they came to medical school because they wanted to treat individual patients, because they were really interested in disease and how they could ameliorate the ravages of diseases on patients. And suddenly they're being told that the problem in medicine is that patients have been treated in a biased and racist fashion. And that's why the disparities in healthcare, which are real and absolutely real, are the result of the way physicians have acted. And that's what they're being taught at this point. And they will come to see that's a falsity, and that, in fact, the reason that there are disparities in healthcare are very complicated stories that have genetic, behavioral, and as well as social components probably to them, but that, in fact, all that the students can do is apply the best in medical care to, treat those problems and to improve the patient's health. So I think they are in conflict, and they will become increasingly in conflict, and they will become cynical when they realize that they're being told things that they just can't do anything about. As I mentioned in a previous podcast, that the physicians' burnout is being attributed in part to the frustration about being told that social conditions are driving healthcare, and they can't do anything about social conditions.
So there's this kind of, I guess, a vicious cycle for a new medical student, a new intern, new resident going into a situation where you see the health problems, and it may be a result of an individual's lifestyle, but you feel that you have to take care of the lifestyle and not the patient. Why are you smoking? Why are you binge drinking? Why are you partying all night? I don't know. Your behavior personally is aggravating or exacerbating your diabetes. Why are you not changing that? And so there's no way you can actually change that community. You have to change the individual. But students are now having this mandate, I guess, from their schools that they have to go out and change the community.
Yes, it's very frustrating
group?
to them. Exactly. Actually, I think one of the ways that the point of view that I've expressed has been cast is we're blaming the victims. We're blaming the victims on their disease problems. And in fact, when one really looks carefully at what the problems are, particularly for the Black community, the biggest problem is not so much lifestyle. Not that lifestyle can't be an important issue. The problem is when they seek medical care. I recently read a study that pointed out for peripheral vascular disease, which is one of the terrible consequences of diabetes, where blood flow to the extremities is limited, particularly the legs. And when it becomes very severe, because of the effects of diabetes on blood vessels, that people have limbs that may even need to be amputated. And amputation rates are much higher in the Black community than when white patients come for the same sort of peripheral vascular disease. But when you look carefully at the details, Black patients are coming much, much later in the course of their disease. So the reason they're doing poorly, yes, lifestyle was a problem, but it was a problem for white patients as well. The ones who smoked, the ones who were overweight. Obesity is very prevalent in the white community as well as the Black community. Maybe more so in the Black community, but not hugely more so. But when they show up for their first complaint about a medical problem, it's much later in the course of illness. So what we're really seeing here is not that they're being treated less well than the white patients. They're seeking treatment at a later stage of disease. And inevitably, at a later stage of disease, treatment is going to be less effective than in an earlier stage of disease. So I think what's frustrating for physicians is when a Black patient, or any patient, but more commonly in Black patients, show up at a point when we know we could have intervened earlier, we could have been more effective earlier, we could have applied treatments that would work earlier, and now we're dealing with end-stage disease as opposed to early-stage disease, and therefore our outcomes are going to be less good. And that is a critical factor. When you look at every aspect of the disparities in healthcare between Black and white patients, what you find is the same thing, that getting early medical care, getting early intervention occurs much later in the Black community than it does. And why is that is the next question.
Exactly.
And the answer to that, of course, is always complicated, and human behavior is always complicated. But one of the factors is trust. It's trust that when you show up at the physician's office, you're going to be treated equally, and you're going to be treated well, and you're going to get the best medical care. And the other issue is, do you have the resources to get to the physician's office early? If a woman is caring as a single mother, has 3 children, and is working 2 jobs, it's going to be hard for her, if she feels a breast lump, to take off and go ahead and get care early. So access to health care is really a critical issue, but also is the trust that when you show up at the physician's office, that the health care is going to be optimal. And this current rage to declare every medical institution as racist and the need to dismantle racism that's gone on. If you're a Black woman and you're early in pregnancy and you're frightened that when you get to the hospital, you're going to be treated poorly, you're probably going to come to the hospital much later in the course of your pregnancy than a woman who's been told you're going to get there and you're going to get optimum treatment when you show up. So this fact that we're undermining trust of patients, and the trust certainly has been undermined over many years. And I see that, I understand that, but this is the time to make the case that trust now is possible, and that the care that people are trying to provide is optimal. And the way to do that is not to continue declaring yourself a racist institution that needs to be purged of all the racist physicians that are working there.
So how do you convey that message to these students who are being introduced to all this woke ideology?
Yeah, it's a tough one, isn't it? Because it's sending a mixed message. We're terrible, we're awful, we're racist, and we're going to treat people now differently, even though we're awful, we're terrible, and we're racist. Well, either you are or you aren't, you know. And I think the evidence, again, has been that once patients get to the healthcare system, once they're treated by the healthcare system, their outcomes are very similar. And unfortunately, when one reads media accounts and personal accounts of healthcare, there's always some anecdotal story of someone treated poorly, and that represents, another example of racism, when in fact, lots of people are treated poorly in the healthcare system. It's a complicated system. People are under a lot of stress all the time, and sometimes their behavior is less than optimal. But that it's not beneficial to convey the idea that represents bias and racism on the part of physicians. I don't believe that physicians behave that way. I think physicians that have been in practice for many years have expressed over and over to us at Do No Harm, and even in writing commentaries about articles they see in the medical literature, that this does not represent the way they treat patients. They treat patients as if they were family members, and their frustrations are that they come late in the course of their illness, not that they're being treated unfairly once they see the physicians.
Let's talk a little about what Do No Harm can do in this situation, to steer students right before we wrap up this episode.
I think we've tried our best to be a place where they can hear some of these heterodox ideas and to understand that there are those who appreciate the fact that they really have gone into medicine to treat individuals, and they're being told they need to treat groups of people in a certain similar fashion. They're being told to treat people in a discriminatory fashion. Mm-hmm. They're being told to treat Black people differently than white people because of these historic disparities that have occurred, when in fact, that's not going to solve the disparity. The way to solve the disparity is to get Black people to be trusting, to show up earlier for their care. Once they show up at the institution, their care will be optimal, as best as these great medical institutions in the United States can provide. The idea is to get Black women to believe that the best opportunity for them to have a successful pregnancy is to go to hospitals that treat lots of people, lots of white women as well as Black women, not to go seek places that only treat Black patients, because in fact the outcomes are worse in those institutions, mostly because they don't have the resources to deal with complicated patients, particularly women that are having complicated deliveries or complicated pregnancies. Mm-hmm. So, it's a very tough problem, but that's what we need to teach them. That's what they need to appreciate, that in fact there is a better outcome that's possible, and the better outcome is early intervention and preventative treatment whenever problems arise in a community.
Okay, well, thank you, Stan.